Thank you all for joining us today for another episode of our podcast, Moving to Value Unscripted. My name is Dr. John Rodas. I'm a recovering ex-hospital president and am proud to be the president of the Moving to Value Alliance. The Moving to Value Alliance, MTVA, a 501c3 nonprofit, is a multi-stakeholder grassroots organization whose purpose, put simply, is to foster a community that aims to create a value-based healthcare ecosystem with high-quality outcomes at a reasonable cost for plan sponsors and their members, beneficiaries, or employees. Our community has grown substantially over the past few years. We started in Connecticut, but now have nearly 1,000 members from more than 40 states all over the U.S., and our members include many value-based influencers. I want to thank our sponsors whose support makes this presentation possible. We'd like to give a special thanks to our trade member sponsor, Connecticut Joint Replacement Surgeons, LLC. We're joined today by my fellow board members, Lisa Trumbull and Dr. Steve Schutzer. Lisa Trumbull is the CEO of Sohn Health, Southern New England Healthcare Organization, a physician-led, clinically integrated delivery system in Connecticut and Massachusetts. Dr. Steve Schutzer, a nationally renowned arthroplasty surgeon, is one of the founders of MTVA and is the co-founder and president of Upswing Health. Joining us today to share their perspectives on independent practice and private equity in healthcare are special guests, Dr. Marco Fernandez and Jack H. Dillon of the Association for Independent Medicine, also known as AIM. Dr. Marco Fernandez is the president of AIM and a cardiac anesthesiologist and president of Midwest Anesthesia Partners, a physician-owned group serving the greater Chicago area. Dr. Fernandez is a fierce advocate in the fight against corporate practice of medicine and has been quoted by many prominent news outlets on the risks of private equity ownership of physician practices. Jack Dillon is the executive director of AIM, as well as the CEO of Anesthesia Practice Consultants, which provides anesthesia and sedation services at sites across Western Michigan. As the resident MBA, Jack focuses on practice management, including how to insulate practices from the risk of a takeover. AIM, the Association for Independent Medicine, was founded in 2022 on the principle that maintaining physician control of healthcare decision-making results in the highest quality of care for patients and the most efficient use of healthcare resources. The organization supports medical groups who choose to remain independent by providing information, education, and political advocacy. AIM has many members across the country. AIM also helped found the Coalition for Patient-Centered Care, a group of healthcare industry stakeholders dedicated to ensuring physicians can work directly with their patients to make medical decisions and deliver patient-centered, cost-efficient care without corporate hindrance. This dynamic duo are well-versed on private practice implications in healthcare and best practices for maintaining or reclaiming an independent practice. Welcome to Moving to Value Unscripted, Marco and Jack. It's great to have you both here.
Thank you. Great to be here.
Thanks, John.
So let me, if I can, just kick it off and ask you both, kind of what got you started? What made you start AIM? There's always we found from our prior guests, there's always some little trigger or some event that occurs that kind of gets people going, I've had enough of this and I want to make a change. So tell us your story.
Well, I'll kick it off. We had our first entanglement with private equity back in August of 2021. So before the pandemic, we were a pretty robust organization. We had 8 subgroups working at 8 different hospitals in Illinois. And then once the pandemic hit, then things started to get a little rough. And we lost 2 contracts within a 2-week period in August of 2021, one to Team Health and one to North Star, both with no notice. There was no request for proposal. We were blindsided. And from there, once we actually lost the contracts, I started to look around for entities for independent groups or independent physicians. I spoke to folks in our specialty society of our state, and then I went and spoke at a town hall meeting at our American Society of Anesthesiologists, where the society basically responded and said they had to remain agnostic and had to represent everyone. And I basically responded by saying that if they're agnostic and trying to represent everyone, they're not really protecting independence. And from there, I got a little bit of traction. And when I walked out of the town hall, people approached me. And then from there, we actually sat down while we were at the conference. And from there, we started to talk about, okay, what can we do if the incumbent societies can't really help us? what can we do to help each other? And that's where I met Jack.
Yep. Thanks, Marco. Yeah, I mean, you left out the several rounds of old fashions that we had in there, but that did fuel us a little bit. But from there, yeah, I think our group kind of felt the same way. Our group wasn't impacted like Marco's group, but we were starting to see these dominoes fall in the state of Michigan, on the other side of the state, and then even locally here on the west side of the state. And then just we're hearing, these stories nationally about, the impact of private equity and what was really happening, especially in rural hospitals. And, all of us, it's not hard to get passionate about this, right? Because the impact goes directly to the patient. And so it was a quick startup of our entity. I think we were up and running in Marco, 2 months. And I think we found immediately 4 other practices that, jumped on board. And now we've got many, many more joining the effort.
It's interesting, Jack, your organization started with some old fashioned, ours started with Tito's. So our roots are similar. I mean, it's a similar inspiration to the launching of the Moving to Value Alliance 7 years ago. Started just a few people literally stayed back after a dinner meeting and said, we've got to solve some of these problems. Had another Tito's, which was the drink du jour at the time. But I'm really impressed with the energy that you folks have amassed so quickly. But let's talk about private equity. And John, you remember this quote. I think I've first heard it from one of our colleagues. Healing is an art, medicine is a science, and healthcare is a business, right? That meant a lot to me. And I'm an orthopedic surgeon. I'm not a businessman. But we've had to learn a lot about business and the healthcare business. And the more I learn about it through my brick and mortar days and now with my startup company, there's a lot of money out there. I am impressed at how many folks that are not physicians or intimately involved with patient care have made millions and millions and millions of dollars. So as I read about private equity, I wonder sometimes if they're naive or unethical. What is their actual intent? Because we know that a lot of companies need, if you look at private equity, I think they peaked in around 2020 or 2021, not by surprise, right? This is when many institutions were strapped financially because of the pandemic, and in comes these saviors with flush with cash. So give us a little background about your thinking about the roots of private equity. What are their interests? Tell us a little bit more about private equity in healthcare.
So when we lost our contract to Team Health, and I was reaching out, trying to find an entity, I did run into an organization called Take Medicine Back. Initially, it was Take Emergency Medicine Back, and I met Dr. Mitch Lee and Dr. Robert McNamara. They're emergency room physicians, and they've been dealing with private equity for a lot longer than anyone else has, for at least a couple decades. And they created a splinter society, if you will, from the American Academy of Emergency Medicine because of what was going on with private equity. And then it seems that it's embedded in some of these societies. And initially, I didn't know, when we first created Midwest Anesthesia Partners, I didn't know much about private equity, but I knew that there were these national staffing organizations that were going around trying to buy groups at the time. The genesis of our organization was to try to protect our market from having those organizations come into our market. And we were fairly successful in the beginning because we were courted by even USAP. And back then, when they would sit down with us, we basically told them, if you did come into our market, we are going to stand in solidarity and you're not going to use our physicians. And that kind of scared them away. Different story once the pandemic hit, and then everyone lost money and everyone's trying to claw it back. And now they no longer buy anesthesia groups. They just roll them up and take over. So over time, I realized, and I learned that they treat proceduralists a little bit differently than they treat the rest of us. With us, they kind of squeeze and sell, and then they buy and build proceduralists, cardiologists, orthopedic surgeons. I think you guys have a lot more to offer with your ancillary services than we do. We're hospital-based. They kind of take us over, and then in our instance, we were an MD-only group. They kind of change the model, and then they start to bring in a lot more non-physicians or certified registered nurse anesthetists as part of that. And if you're top heavy with physicians, eventually they start replacing you with non-physicians. And since we knew a little bit about private equity, we knew that they have nothing to offer that we can't do for ourselves. And we had great back office folks, And luckily, we had great leadership with enough foresight to educate us, and then for us not to fall into that, realizing that we want to be in charge of patient care, and we didn't want anyone else to dictate how we were going to practice, the kinds of ratios we were going to have in terms of supervision. And we thought there's no better advocate for a patient than an independent physician. And that was our thought process along the lines. And lo and behold, pandemic hit. And now you hear all these horror stories where private equity comes in, they make all these promises to hospitals, and they can't deliver. And so there's major disruption of these programs, surgical programs, and all the trust and respect is gone. And you just have a revolving door until you're fully staffed, which can take years of fresh faces, weekly, daily. And how do you build trust and respect? And for us, we were always very proactive and nurtured the emotional side of the business equation. So our foundation was always built on trust and respect. And if you're going to have a culture of safety, you need that. And I don't see how you can possibly build that when you have temporary workers flooding your program, all to try to save a dollar. And so we basically are doing everything possible. Even when we lost our own hospital contract to the hospital, we were able to stay together, and we pivoted, and we created a subdivision or a subgroup within our organization that does a little bit of locums, but then we started to pick up contracts with the relationships we already had at surgical centers. So we're trying to create a little bit of a hybrid so that we can flex with the market as it changes. And I think we've been very successful. We've only been doing this for about 6 months, but we doubled our contracts within that period just because we're trying to fill that gap. And at least that's my experience in my market, but Jack can fill in what's going on or what his thoughts were in his area.
Yeah, no, thanks, Marco. My business perspective and 30,000 foot view, and as we connect with not just anesthesia practices, but a lot of independent practices, you know, as Marco said, like the value proposition to proceduralists and surgeons might be a little bit different than they are to anesthesia, as well as I think the other, you know, if you know the acronym PAIR, pathology, emergency medicine, anesthesia, radiology, those very, we'll call it staffing power-driven services, right? Where it's, at least in today's healthcare climate, about do you have the level of staffing to support your need, right? And that's kind of the biggest quake that's going on. But when you look at those services, the private equity, the large national, we don't hear good outcomes and good stories, right? Like we hear how they've kind of come into markets and overpromised and underdelivered, and it becomes devastating to those communities and to those hospitals. And so a lot of our focus has been exactly what Marco said. They're coming into the hospitals, and you know, maybe you're upset because you don't feel like your anesthesia group is giving you the coverage that you feel that you need, or that they're too expensive, or whatever that those things might be. And those conversations might be true in some of these negotiations, but I can tell you that the firms that come in are going to tell them what they want to hear and overpromise what they can deliver, and then slowly that'll begin to break down, and that hospital's left in the rubble. And rather than just complain about it, the thing that we, Marco and I and the rest of our team, want to focus on is really helping practices and say, you can do this yourself, right? Like you can take the approach that sometimes these firms are taking, and the optics of, you know, hey, what does that relationship look like to quote unquote win that contract or keep that contract, and do it as an independent practice. And so that really, I think, is the message we want to get out there, is don't let the pressure of that private equity, that big business, infiltrate and then ruin what is probably a relationship that just needs to be tweaked a little bit. And so, yeah, I'll stop there.
I think it's great to hear your journey here, and certainly there's a lot of criticism publicly of private equity and a lot of disasters that communities are left picking up. And when you focus on the fact that you want physician independence and decision making and in the clinical management of patients, how do you see relationships like payer employment of physicians and hospital employment of physicians? Do you see that the same way, or do you see that differently? And then the second question is, I think it would be helpful to the audience to understand what are the goals and how are you looking to address this issue with your organization?
So I'll start off. In terms of payers and hospitals, for me, they all use the same playbook. Yes, hospitals are more invested, and They may not blindside you and walk away, but I think they don't want to pay physicians, and they, depending on the specialty, want to replace the physicians. So, United Healthcare now owning over 10% of physicians, and then now 78% of us are now employed. I think they're all doing the same thing, but I think private equity wants to get in and out. So it's much shorter term. They want higher returns on their investment. And my goal as the president of AIM has always been to try to unite as many folks as possible, to unite our efforts and maximize our resources. We're educated, we do have resources. And I think that if we all just organize, not necessarily unionize, but I think that's going to be the next big thing on the horizon with so many of us being employed. And you see now residency programs are unionizing. The goal is to try to just come together. There's enough threads there that we have in common that can easily unite us. I think that our narcissism of small differences, which is a great podcast, by the way, keeps us from really coming together and creating that impact. But I mean, as Jack has told me previously, we need to really invest in advocacy. And I am a member of as many groups as possible because I realize that, yes, it affects me on the professional side, but it also affects me as a patient. And we're going to feel the shortages of physicians and staffing at the hospital when you have to be there for prolonged periods of time. And hopefully it's not for any kind of severe illness. I did lose my mom last year, so I did experience it on that side. And she was at my hospital. So I had some level of comfort thinking that I could easily navigate. And so she would be well taken care of. Well, she was taken care of very well by physicians, but with the nursing shortages, she didn't get great care because she was there for a prolonged period of time, and she did pass at the hospital. So I think we also need to realize that this isn't just about dollars and cents as professionals, but this is also about our loved ones being in that system. And I think that if we were to look at it from that perspective, I think folks might be a little more motivated and some inspired to get involved and invest in what we're trying to do.
First of all, Margaret, sorry for your loss.
Thank you.
You could be prepared your whole life to lose a parent, but it's still, you're never really quite ready. So my sympathies. So as a former chief medical officer and former hospital president, I have to honestly say that I've had numerous issues over the years with these so-called pair groups that you're alluding to, Jack, the pathology, anesthesia, radiology, and ED, which are often contracted groups with hospitals, as you pointed out. And truthfully, I've done both. I've spun some off from employed to private, and they've done great. And I've also taken some in and brought them in-house and made them employed. But I would say in general, hospital executives and CMOs in particular never want to get rid of their pair group and swap it out with somebody else because it's very, very disruptive. And usually, in my experience, there's only two reasons you ever do it. You're not getting good service, or the subsidy the group requires is at least you deem excessive, right? That's my own experience. So I get it. But I guess my question to you guys is, are you focused predominantly on those pair groups and trying to help them manage that space? And of course, to your point, there's been a lot of consolidation in the private equity, specifically in those areas. But there's a lot of now private equity and consolidation going on in other areas, including cardiology and orthopedics. We can go down the line, a lot of them. What if I'm a private group and a 10-person group, let's say, and I'm trying to stay private, not a pair group? You guys help that kind of group stay independent, tell us how to do it. And on a flip of the coin to the other side, and I've acquired plenty of these over time, I've acquired a private practice group and I've under-delivered to them, as Jack alluded to, and now they want out. They want to get out and go back into private practice. You guys help both sides of that coin and just elaborate a little bit more of the nuts and bolts of what you actually do for folks.
Yes, yeah, absolutely. Thanks, John. That's exactly right. It's become all of it, and it isn't specific to the pair groups or anesthesia. We've got primary care, we have orthopedics, we've got everybody. We've got veterinary and dental that have reached out for help and support, right? And so it's been all walks of life, which I think, before we go any further, right? Like, I think that exemplifies how big of an issue this is. I mean, we've been around for 2 years, and we probably connected with well over 100 groups who have needed help in small doses and others that have needed larger help, right? And so it's a bit of everybody and everything. And so I think a couple of things with that is that what we're trying to offer groups is, we started a series in May of what we call toolkit sessions. And I joke with Marco, when people ask us, well, is there a playbook for practice management or how to run your practice? And Marco and I joke, it's like me asking him, hey, can you just tell me how to intubate somebody? It's practice management is lived, right? And running a group, whether you're CMO of a hospital, right? Like, you learn on the job, and those things, yes, you can try to document them and write them down. And there are certainly bullet points that we can share, but really it's being part of the conversation and the ongoing support. And so that's why we develop these toolkit sessions. It's a monthly session where we invite everybody free of charge. Come talk about, we just had one this week. Come talk about recruitment and retention. Hot topic anesthesia is what are groups doing? And we have an agenda that guides it and some tips and tricks and some documents that might be able to help groups. But really, it's more about being a part of the conversation and learning from one another. And even my group, that I think we do a really good job in our market, got to listen to other groups. And I was like, man, that's a really good idea. We should do that, right? Oh, that's a good idea, right? And I think that level of support and being able to engage on the things that you want as a group or might need as a group, because I think you hit it, John, right? You might really love the people in that group, but maybe that subsidy is too high. Well, then that's an avenue we can assist with and help coach that group on evaluating that financial impact and what the staffing model is and working with the hospital. Or maybe it's, you're not getting the service you need. Okay, well, let's evaluate that service and help coach groups on what are they really asking for and what is that gap that you see. And so that's exactly what we're here to do. We want to focus both on that practice management support, as well as Marco said, on that advocacy support, to send that message that just because you're signing up with this large national firm that has a glossy website and can send you a crisp document that makes it seem like they can do all the things that you need them to do, again, rarely have we seen that actually happen. And most times it gets worse, not any better.
And I think that if folks are employed and they want to go back to being independent, we're there for them as well. We're willing to talk to anyone about what's going on and if they want to change something. And we can at least, if we can't help them directly, we can at least point them in the right direction.
Yeah, that's really important, Marco. And I'm going to ask a question from I'm an orthopedic surgeon, a joint replacement, very, very much a proceduralist. And I think to myself, the last 4 or 5 years, when I've really heard about private equity moving into our space, what would the motivation be for a practice to sell, right? And I can think of two. One is everybody else is getting bigger, right? And health insurance, health systems are getting bigger, the payer community is getting bigger. And to have a seat at the table, a group of 4, 5, 10, 30, not enough, right? I remember hearing from an orthopedic colleague that a group less than 100 can't afford the infrastructure to compete. So, John, remember, I don't know if you follow Stacy Richter, the last podcast was the ideal group size was 10 to 14. Yeah, and Marco, that's because of the thing that you brought up, a culture. You can develop a culture when you're in a small group. Ironically, the management company CJRS, John, had 12, so we were culturally important. So there are two reasons. One is that there's this pressure to get bigger, right? You just can't do it alone anymore. Second one is the financial benefit that accrues to the senior practice partners to sell out. So I had a conversation last night, ironically, with a colleague who has a 35-person practice. They've got an ASC, they've got an MRI, but they're going to sell out. They had 3 private equities competing for their business, and they went with one. Why did they go to the one? Because it had the bigger first-year payout. And that's just the way it is, Marco and Jack. And, back in the early days, the 50s and 60s, there were small physician groups that would sell their practice, right? So when I turn off my lights, I just disappear. I have nothing to sell. So I get the fuel for this, right? Folks get a retirement, right? They're 65, 68 years of age. They get a 5X multiple. It's a hard one to compete with. So how do you deal with that dynamic, which is very forceful? How does AIM deal with that buyout phenomena?
At least for anesthesia, we don't have that. They don't buy us out.
Yeah, there you go.
But I understand. And in those groups where there is a buyout, what happens to the younger folks?
They get screwed. Yeah, the young people get screwed.
Yeah. So and then you have to wonder if in those instances, in those markets, is there transparency and accountability with those buyouts? And if there's corporate practice of medicine doctrines that already exist, are they updated or being enforced? So I think a lot of these deals are happening and really no one's really looking at them. And I think a lot of the physicians at times focus on the money and really don't know what they're getting into. And if you're on the cusp of retirement, we all know you're going to get out.
Doesn't matter, right?
You're going to walk away. You have your pot of money, and that's all that matters. So it does make it extremely difficult. But at least for anesthesia, what I think has motivated quite a few of us is that there's no buyout. And even if there was a buyout, we already know that, yeah, they'll pay you a lump sum in the beginning, but then the rest of the group, they don't really have a future there. They're all looking for ways to get out. And in our market in Chicago, there's so many opportunities that's why you have an exodus at any of these institutions. They can go work locums, they can go work for another private group, or they can get employed with one of these other health systems that will treat you better. And that's what some of our folks did. But we chose to stay independent because we basically wanted to manage our business. Jack, why don't you?
Yeah, and I think just building off of that, if we're very honest, and yeah, I get a lot of questions about the history, especially as where there were those buyouts, especially from the large national anesthesia groups, and those have just completely gone away, right? And I think that has more to do with, at least in the anesthesia world, in my opinion, to do with these groups feeling like, well, we can just come in and take the contract. We don't need to pay a dime. We can just take it and those people will come work for us. And I think that that's a very dangerous mentality that's happened over the years and really has created the instability nationally. But I think as we're moving forward, and Marco's doing it in his market, there's a lot of other groups that are part of our network and that we've spoken to. The growth for anesthesia has been dramatic. I mean, every group I talk to is experiencing at minimum a 5% growth in volume, not even from taking on new services, but just that natural growth of non-operating room anesthesia, right? More MRIs, more cath lab, more IR procedures. Groups that were not doing any endoscopy in the past are now completely covering endoscopy. But we didn't account for this volume in all the training programs. I think that they're trying to catch up, but it's never going to be at the speed that's needed. And we're going to deal with this for a while. So the very dark scenario for me, if you're looking at this like an asset liability PE group, is that the anesthesia asset is going to be more valuable as time goes on. And the group's worth is going to only increase. The individual's worth is only going to increase. And anesthesiologists and nurse anesthetists and anesthesiology assistants are aware of that. And that's why you're seeing more of them go into locums individually, more of them, take carve out jobs where they're looking for that work-life balance. And who can blame them if the market is after them in such demand, right? And I think that has a pro and a con, right? It's a pro because for the profession of anesthesia, your value is going up. That's always a good feeling. The con is that we, and I know Marco's group and all of our groups, what's our common thread? We're independent groups that want to be good partners and serve our communities. But if you go in a negative path in this, right, we can see where this is going. If you hold that asset, you can hold it over people's head and you can go to whatever that next great contract is and kind of decimate communities and hospitals. And that's the fear. And so that's why we encourage groups to be good partners, figure out good pathways, and not allow this to happen in their settings.
Yeah, I think in your responses a couple times, I've been in healthcare for over 35 years now and lived through the public practice management days in the 90s, right? Where we acquired groups, sold groups, consolidated, and then the whole thing collapsed. And this feels a little bit, like that time period. And to bring it back to a couple of the comments that you made, that physicians, when they do this, a lot of times the motivations are, I don't want to deal with managing the practice environment anymore. It's too complicated. I just want to deal with my clinical work. And, if I happen to get paid in the process, that's okay with me. But then they, to your point, don't realize what it actually means to be in one of these entities, right? That have margin targets and investors that they need to please. So when things don't go right in the market or when they're not meeting their margin targets, the ramifications are that, the physician, there's more pushing of the physicians to do things that may be on the edge I'm not saying this is generally the case, but maybe questionable on the edge with some particular private equity companies. And I think that that's the danger that you're raising with an investor class being involved in the delivery of healthcare. And I'm wondering how you see that with your organization and what you see as solutions for physicians. And then I have a follow-up question for you after that.
Marco, you want to take it? You want me to jump in first?
Go ahead, you jump in first.
Yeah. So I think, the first thing, at least for in the anesthesia world, but I don't want to speak for the other payer services or services in general, but if we're going through it, and I know a lot of those groups, I know that they're going through it too, is that the first step is, honestly, it sounds so simple, but we all got to take a breath when we're talking about contract and financial support and things like that, and really focus in on what are the mission and goals of both sides, right? What's the mission and goals of the hospital? What is the hospital trying to achieve? And then same thing with the group. What is the group feeling and also trying to achieve, right? And making sure that those things are aligned. It sounds so generic, but it's true. We see that time and time again, that if you don't have that alignment, it's hard to get started on the rest of it. So assuming that alignment is there, I think really utilizing the staff and the resources and the availability and really scrutinizing that is got to be the first immediate step. Training people is going to take a long time, right? We know that. And even getting institutions and other programs is going to take even longer. And so the immediate step is to really look at, hey, this is the hand we're dealt. This is the staff that we have available. And this is what it can realistically cover. And how can we improve that operational efficiency? We do this work continuously with sites, and still there are very reasonable changes that can be made to make the days run better and both and all parties be happy. And I encourage more of that collaboration, because I think when you're in a hospital administration position, and I worked a hospital for 13 years before going into private practice, right? You're kind of looking at, well, you're moving on from one brush fire to the next, and it's how do we solve this issue? Well, the solution always seems, well, we'll just add more people and then we'll be able to cover the work, because that's what we're hearing. If those people don't exist, it's really hard, and then it's very easy to get frustrated with the service you're being offered. But I think taking that breath and taking a step back and saying, hey, how do we align first and figure out what's working, what's not working, and then identify that gap and need is the most immediate step you can take, and then talk about what future state looks like.
That's really hard when folks feel like they can't hold their head above water. And so the next easy thing to do is just to be like, forget it, let someone else deal with it. But I think we're having more folks approach us about, okay, we're having difficulty, what can we do? And it varies from group to group. But I think Jack's expertise with his MBA can put them at ease with one phone call. And I've seen this happen over and over again. We're like, oh, I didn't know I could do that. Oh, really? And so it's just a matter of having those conversations. And that's why we kind of want to create this network, even if it's just having conversations and we get nothing out of it. I think there's a lot that we don't know. They don't know what they don't know until they see something on social media that we post and they reach out, or just in having conversations by word of mouth in our market. And to me, it's still amazing that, someone just asking a question will really change the direction, the perspective that they're in, and give them a little bit of hope. Okay, then maybe we can do this. The last conversation we had, they're like, we just got a new manager. They want to sell us to PE. And we're like, whoa, time out. And then we just ask a bunch of questions, and then we realize, then we start highlighting where there are potential opportunities for them to, as Jack said earlier, try to tweak something, and then you can start moving in that direction, which is not easy to do when you're in the middle of what feels like you're drowning. And that's where we're trying to fit in.
Lisa, you got a follow-up, I think?
Yeah, I do. I'm interested in understanding your perspective on how much the reimbursement model in healthcare actually is creating the situation that we're facing. I mean, there was, just an announcement with MedPAC suggesting a 3% decline in physician rates at a time when there's physician shortages and you need physicians to do the work and manage the physician-patient relationship. Certainly from a viewpoint of private equity, the more you do, the more you get paid, the more return there is, right? And I'm wondering how you think about that and how active you may be in terms of, lobbying or trying to facilitate change in that direction.
Yeah, so that's the biggest issue. I mean, you nailed it, right? I mean, the reimbursement in anesthesia is atrocious, right? It doesn't even cover, the cost of staffing by a wide range, right? And so, last year anesthesia was hit with CMS hit with a 3.9% decrease, and now we're talking about another 2. So our 33% problem, which is, if you don't know that term for anesthesia, we used to be reimbursed for Medicaid, Medicare at 33% of what the commercial reimbursement was. Now it's going to be less than 20% of what the commercials pay us, right? And so it's going to get worse. I mean, I heard one physician in our network say it, is this a concerted effort to get rid of independent practice, right? Because it certainly feels like that. And let's be fair to the hospital side. And John, you live this, right? Is that the solution cannot be go to the hospital for more money every time, right? It just can't, because the hospital's got a budget, the hospital's got to pay, right? Like, those are realities for the hospital. And so this is an important conversation about what this is going to look like. You're going to get more physicians that are just leaving the profession entirely because it's not sustainable. And so the reimbursement piece is big, and we really need to do more work on all fronts and all specialties to really call that out. Even the disparities within states where the payer rates between one group and another are different. I mean, that exists and it shouldn't. And so we really need to dig in. We have this conversation, but this, quite frankly, is a big undertaking. And there's a lot of groups getting organized on this topic, groups that Marco and I have connected with. And really, this is, I think, going to quickly become the number one thing that we work on. Luckily, the hospitals, and this is exactly where groups like ours, whether it's AIM or whether it's an independent group, are very aligned. I can tell you that as soon as this news rolled out, I had many centers leadership reach out to me and be like, here we go. And so you at least felt that sense of, okay, this is all coming to the surface where we're having more real conversations about, oh, well, if we're getting paid less than hospital X, you need to pay us more. It's really, this is a problem, and how are we going to actually be able to pay for the staff needed to just cover necessary services?
I wish you guys were around when I had my challenges with my contracted groups, because I love the entrepreneurial spirit that people like Dr. Schutzer have. But for every one of them, there's a lot of poor businessmen that are in these practices. And if they could just be more efficient, be more cost effective, enhance their revenue, manage their practice better, they wouldn't be coming to the hospital, to your point, with their hand out saying, pay us for, our shortfalls. And I love the other point you made, Jack. It's really important, is the alignment. What are the goals? And I think that when I've, again, historically had these challenges, there was always this breakdown of communication where I was very focused on service, and they were just focused on their, I'll call it work-life balance, and somehow I was supposed to subsidize that, and at least that was the perception, and we couldn't meet eye to eye. So I love the fact you guys are out there. I want to just pivot, if I can, and ask you a little bit about the Coalition for Patient-Centered Care, because I think you guys, Mark, I think you were part of the founding of that organization, and I just want to understand a little bit of what they do, if you don't mind sharing that.
Their focus is private equity and transparency and accountability, holding these entities accountable for their actions in healthcare. But they wanted to include consumer protection groups. So they were taking a little bit of a different, it's not just physicians. They wanted to bring in organizations that were already involved in Washington, trying to help and protect consumers, protect patients. And those are the groups that we're trying to align with and bring them in, and bring in physicians from all specialties. And they have a pretty strong lobby organization with lots of ties to legislators all over the country. So, I'm very excited about the growth and the future of the organization. And I'm glad that we were one of the founding members, and they reached out very early on. So I think there's going to be a lot happening. And as time goes on, we're trying to bring in other grassroots groups into this movement. And I think that the announcement of this new reimbursement cut is only going to fuel folks to get more involved and to invest in advocacy, or get directly involved in advocacy by either running for something or just going to conferences where legislation is the main focus.
Got it. Steve?
I've got a question, and then, like Lisa, a follow-up. John and I both took the value measurement and healthcare course probably over 10 years ago, John, with Porter and Kaplan. And I think from both of our perspectives, that had a major impact on our own mindset. And as an orthopedic surgeon, I like to think of things very simplistically, and I think of the value equation. outcomes that matter to the patient for whatever problem they have over the true cost of delivering those outcomes. So it's outcomes over cost. And yet we know that a third of healthcare can go in the toilet and no one would miss it, right? So when private equity first came in, I said, oh, this is a good idea. I need some cash to do what I need to do and to reduce the cost and reduce the denominator. So you would think that by reducing the cost, value would improve. That hasn't always been the case. I read the article a couple of months ago in JAMA. I guess it was about the Steward hospital system. And, the outcomes were dismal. I mean, it was pretty objective data that I think it was falls, maybe infections and other complications were higher. Is there anything that shows that reduced costs through private equity, which is a good thing, actually improves outcomes?
No, not at
Not
all.
aware.
I think we should continue to use the analogy of, like I said, it's like Marco calling me on the phone and telling me how to intubate a patient. I mean, isn't that the same, right? You have these private equity firms who don't often know much or anything about healthcare coming in and trying to run. And I mean, one of the things that I note is that they're not always putting effective clinical and physician-led leadership in place to ensure that things stay stable or improve, right? They're worried about the dollars and cents. And when they're short-staffed, I mean, I'll speak to anesthesia, that department chair or that medical director that they've appointed is going to start working clinically more, right? And then they're not able to address the things that are going on. That's been my impression of what happens, and a lot of the maybe soft reason. And I don't have any research to back it, of course, but when I read these articles, when we talk about these situations in different states with other groups and what's happening, you can easily put these pieces together to say, well, it makes sense what happens, right?
So how does private equity reduce costs?
Cutting staff.
Yes, exactly. So I don't understand how you can improve quality if you're cutting staff or changing out staff or replacing physicians with non-physicians.
That's right. Professor Kaplan, I think Derek Haas, you may recall, wrote an article, How Not to Cut Costs in Healthcare, and that was one of them. But so I think, listening to this conversation and reading, we all know our perspectives that we would view private equity in healthcare as being the pariah and not a savior of healthcare. But let me just present the counterpoint for a moment. So, and I hate to paint an industry with one broad brushstroke, because our organization is looking at maybe rolling up into, there's USOP, there's AOP, there's HOPCO. I assume you folks are familiar with those. And we're particularly interested in HOPCO. I followed these guys for 15 years. And these are orthopedic surgeons who really do understand value-based healthcare. They're backed by several private equity, but their board is as majority of physicians. Their chair is an orthopedic surgeon. And really their mission is to provide the infrastructure to smaller practices to move to value-based healthcare. It really is a noble mission. How to learn to contract with direct contracting, with Medicare Advantage. And that really is their mission. So they're brought in under the category of private equity, but they're not quite the same, right? So there is some subtleties and nuances that we just maybe want to take a little more clarity on throwing everybody under the same private equity bus. What do you think about that?
There has to be investment in healthcare, and it's just a matter of controlling ownership. Is it a corporation practicing medicine and everything, or are they truly interested in delivering quality care, efficient care? I don't have any problem with that. It's just a matter of figuring out how do you know, and I have no problem with folks wanting to make healthcare better.
Yeah,
I think that's a great point, Steve. That's a great question. I mean, there's certainly, and we have this conversation. Actually, you mentioned Stacy Richter before. We have this conversation all the time when we talk to new potential partners. Our question is very clear. Are you in it to just take some profit out of the system of the $4.3 trillion target? Or are you there to actually enhance the system, make it a little better, and make a little profit for yourself? That's okay. And I think it's that latter, partnership you're looking for. I had a question, and maybe, Jack, when I introduced you, I said you're the resident MBA for the group, and you're reminding me of, myself, when I knew I was going to be the president of the hospital. I said, oops, I better get an MBA. And I did. So a little later in life. But I think going back to my earlier point, leadership is so important in all of these groups. And a lot of groups start with, one or two people, and they grow over time. And one of the failures I've seen over time And both with my contracted groups and private groups, but especially with the contracted groups, is a lack of succession plan and lack of real true business acumen. They might have a good, they've gotten better over time. We bring in people like you to help them kind of manage the practice. But how important is it for the physician leaders to also have some training? I'm not saying they all have to have an MBA, but how do you feel that's very important? And then just tie in that succession planning component. How important is that when you consult with other groups?
No, I think this is also a very timely topic, John. A couple of things that I think it's incredibly important, right? I think the business of healthcare, from my perspective, is a collaboration, right? I work with Marco. Marco works with me, in my day job, in my regular job, right? I work for the physicians, right, and the board of physicians, but it's always felt like a partnership. And there are skill sets that I have, and there are skill sets that the physicians have that, when we combine those things, make us very good at what we do. But there's a little bit of that understanding that I need on the clinical side and they need on the business side. And you nailed it. You don't need everybody to get a full MBA. We continue to partner with each other and ask questions. Even last week, I had the question, I've learned a lot over the years when it comes to surgery and anesthesia, but, I asked the question to my physicians, hey, what would make an endoscopy urgent or emergent versus routine? And got, immediate text messages back, like, this is the criteria, this is how I view it. And then you can even see that discussion amongst a couple of people of like, well, this is what I would consider versus that, right? And sharing that is both, I think, beneficial. I like it because even though I've been doing this for a while, it's continuing to my professional development. But absolutely, I think it's important. I think carving out time for physicians and not having physicians do the administrative work off the side of their desks is really important. But I think what we classically have done, and John, you probably have seen this. I know Marco feels it because Marco is a phenomenal physician leader and does a lot. But we often have also, when you're good at the leadership thing, we then pile on everything onto that physician leader. And what I think is a better wave, and especially for the generation of the physicians that are coming out, many of them want to participate, but they don't want the whole lot of the role necessarily. Right. So how do you splice up those things? How do you start out a physician who's 2 years out of training, who really is interested in leadership? Well, get them on a committee, right? Get them started small, build them up. And then, finding those programs, that the ASA, I don't know if it still happens, but the ASA used to partner with Northwestern University on a leadership, specific to anesthesia and business. And there are a lot of resources. I'm constantly sending those things out. Like, yeah, before you consider an MBA, maybe, listen to these podcasts and learn from, free resources. There's a lot out there. But I think it's wildly important. Do they need everything? No, but giving them that basic structure and figuring out ways that, hey, what are you interested in and how can we support that is very important. Last thing I'll add is an internal committee structure for every practice, wildly important, right? It doesn't have to be huge. It doesn't have to be a lifelong sentence. That's also, right, if you were on a committee, it's forever, but getting a good rotation, getting people in the loop, it keeps everybody active in the practice.
As we start to wrap up a very interesting and timely conversation, Marco and Jack, first, thank you for joining us today. And thank you for all you're doing to maintain the sanctity of our practice. We owe it to our patients to do better. It really is very, very disheartening. So let me ask you a good wrap-up question here. Put your thinking caps on, your visionary caps, and what's going to happen in the next 5 to 10 years? I've been thinking about in terms of orthopedics. I think the economic lure of these buyouts for the senior board dominating orthopedic surgeons is just going to be too hard. And I get it. And it is going to screw the younger folks. But what's going to happen after a resale in 3 years, maybe another resale, I think it's going to be reborn again. I think these guys are going to say, we got screwed. Now we're 42 years old, not 32 years old. And I think it's going to come back in a different shape or form. So you folks must be thinking about what's going to happen in the next 5 to 10 years. Give us your thoughts and insights from where you sit.
I think that with everything that's happening, more and more of us are getting educated, whether we like it or want it. We're definitely learning more about economics. We're learning more about politics and how that affects healthcare and reimbursement. So as time goes on, I think the pendulum will swing the other way. We already know that in certain markets, private equity is exiting. I think they're adapting and finding new areas to invest in healthcare. But I think, at least for anesthesia and what's going on with Envision in California and USAP in Texas, over time, we want to create an organization so that when they do exit, they have somewhere they can go to just for information on how, okay, now we're trying to pick up the pieces and rebuild. How do we do it? I think that's what will happen in the next few years. And my goal is to try to educate folks as much as possible within that time frame, just to having conversations, social media, podcasts, whatever I can do. But I'm hopeful. So I'm very hopeful.
I like the optimism. Jack, any final thoughts?
Yeah, no, I appreciate it. I think, what we're finding in a lot of spaces is I think there's going to be a lot more transparency and a lot more autonomy, right? I do think that the market of all places of work in and outside of healthcare are driving towards that. And I think independent practices have more of that ability than anybody else to create that and choose where they work. And so I think we're going to see more of that and maybe a little bit less of the status quo, which, I don't want to make it sound like a bad thing. We still need to care for the patients, don't get me wrong. But I think we're really going to think about how people work and what is deemed urgent, emergent, and how do we really take care of our people, right? You all are physicians, I am not. And that's top of mind for me every day. Are our people okay, right? How do we ensure that going forward, I think is the biggest priority.
Right. Thanks for that. And thank you so much both for being here today on MTVA Unscripted and also for what you do to help support those practices that are out there that want to stay independent or go independent. And thank you so much. So Marco and Jack, thanks so much for joining MTVA today. And Lisa and Steve, as always, thank you for joining the conversation. And we'll see you all soon. Have a good day.
Thank you all. You too.
Thanks, everybody.